Hello everyone. Today I'm going to start with anti-hypertensive, that is blood pressure medications for high blood pressure. So this is going to be part 1. So let us first understand how the antihypertensives, the commonly used antihypertensives act. Where do they go and act in our body? So let's first understand the RAAS system. What does RAAS stand for? The renin, angiotensin, aldosterone system. So the RAAS system, the renin, angiotensin, aldosterone system, is basically, it's a homeostatic mechanism. It regulates the body electrolyte, the fluid volume, and the vascular resistance. So under normal conditions, it helps in maintaining the blood pressure. It prevents the blood pressure to drop. Okay, and so I'll first draw the chart of the renin, angiotensin, aldosterone system. So first we have the angiotensinogen. This protein is produced in the liver. Angiotensinogen is converted to angiotensin 1 by renin. And where is renin produced? Renin is produced in the kidneys. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. Angiotensin converting enzyme, ACE. ACE is produced in the lungs. Now angiotensin 2 has the property of causing vasoconstriction. Okay, and therefore it helps in maintaining blood pressure. Angiotensin 2 further will cause the release of aldosterone hormone from the adrenals. Where are the adrenals? The adrenals are on top of the kidneys. So it will cause the release of aldosterone. And what does aldosterone do? It causes sodium and water retention, meaning it will prevent the excretion of sodium and water through urine. And by retaining sodium and water and releasing potassium or excreting potassium, it is helping in maintaining the blood pressure. So under normal circumstances, imagine a patient's blood volume is suddenly decreased, maybe due to blood loss, or the BP is falling. What will be the response? This happens in our body, and aldosterone will cause sodium and water retention, and therefore the BP will be maintained. Now, most of the major class of antihypertensives are targeting this system. So, the first class of drugs, the ACE inhibitors. ACE inhibitors. And how will you identify, or what are the ACE inhibitors? The drugs which has a suffix or ending with a prill. Captopril, enalapril, lisinopril, right? So all the antihypertensive or the drugs ending with prill comes under the class of ACE inhibitors. Now in this, can you say where the ACE inhibitors are acting? They are going and inhibiting this enzyme, and therefore the steps below that is not happening. So angiotensin 2 is not produced, aldosterone is not produced, and therefore instead of sodium and water retention, now there is loss of sodium and loss of water, and it will help in bringing down the blood pressure. So it can be not only used as an antihypertensive, it can be also given in case of diabetic nephropathy or heart failure or LV dysfunction, because it basically is reducing the load on the heart, right? You're losing sodium and water. Okay, so the first class is ACE inhibitors. They go and inhibit this, and therefore instead of sodium and water retention, there is loss of sodium, loss of water, and retention of potassium. Okay, now moving on to ACE inhibitors. So ACE inhibitors is used to reduce the blood pressure and other conditions like heart failure, post-MI, LV dysfunction. Now, ACE inhibitors, what is the primary adverse effect? So, what you have to watch for? You need to watch for when you administer a prill, ACE inhibitor or any antihypertensive, especially when you are administering it the first time, you have to watch for hypotension, a sudden drop in blood pressure. And therefore, what we should do is, if the patient is taking any other diuretic or antihypertensive, stop that. Wash the patient after the administration of the first dose. You have to watch for hypotension, okay? The patient like lightheadedness or anything like that. The other major adverse effect is dry, non-productive cough. So what happens is the ACE, angiotensin converting enzyme, is also called the kinase. This normally breaks down bradykinin. Now, since you're giving an ACE inhibitor, bradykinin accumulates in your body, and therefore it can cause the dry, irritating, non-productive cough. Now, if the patient complains of cough, it usually, if it happens, it doesn't go away. So, either you'll have to switch to another antihypertensive or give antitussive drugs. So, dry cough, very important side effect of ACE inhibitors. Another thing about ACE inhibitors is it is teratogenic, so it should not be given in pregnancy. Don't give it in pregnant patients. And third thing is there is a risk for angioedema. So angioedema is something like hives. There could be swelling under the skin and mucous membrane. But when does it become dangerous? If the swelling is in the larynx, the back of your mouth, the tongue, it obstructs the airway. So the patient will suddenly develop breathing difficulty. If that happens, you have to give IV epinephrine, EpiPen immediately and have the resuscitative equipments ready. Then another thing it can cause is it can bring down the WBC count, the white blood cell, the neutrophil count. It can cause neutropenia, lower it. So the person can become more prone to infections. So the first 3 months of starting ACE inhibitors, every 2 weeks we need to do the complete blood profile, monitor the blood count. After 3 months we can do it periodically. So we did the adverse effects were hypotension, dry non-productive cough, angioedema, neutropenia. So these are the frequently asked questions, and it ends with a prill. Important. Now, I said there is loss of sodium and water and retention of potassium. So there is a risk for hyperkalemia. Hyperkalemia means high potassium levels, which can present as paresthesia, weakness, or ECG, EKG changes. And therefore, we have to monitor the potassium levels and ask the patients to avoid potassium supplements or potassium-rich food. In the part 2, I will move on to the other antihypertensives. That's all for now. Thank you.